Dr. Doyle has a long-standing interest in ENT anesthesia and difficult airway management, as well as an interest in the use of technology in medicine. He is going to take us today to an interesting lecture titled Anesthesia for Interventional Pulmonology. Dr. John, we are all listening to your
corrected. Okay, let's get started. Today, I'd like to talk about anesthesia and airway management in interventional pulmonology. And a lot of what I have to say has to do with our experience at Cleveland Clinic in Cleveland, Ohio, which you can see in the screen here. Later on, I'll show you pictures of our bronchoscopy suite, which is truly state-of-the-art. The objectives for this presentation is to introduce you to bronchoscopic procedures, especially bronchoscopic lung volume reduction surgery, tracheobronchial stenting, some endobronchial procedures such as navigational mediastinal biopsy and endobronchial ultrasound, some anesthetic techniques pertaining to bronchoscopic procedures, and the use of dexmedetomidine in airway management, which is something that we've been doing for some time. I'm going to introduce you to some relatively new procedures: endobronchial ultrasound needle aspiration, cryotherapy for benign airway disease, and stenting as a salvage therapy for lung transplant dehiscence, because we do a lot of lung transplants at Cleveland Clinic. There are a number of procedures that are now recently approved or on the horizon. The Food and Drug Administration of the United States has recently approved pleural dye marking and fiducial implantation as means of identifying various structures for subsequent surgery. They've approved complete endoscopic bronchial ultrasound for mediastinal staging for malignancies, and treatments for emphysema and other benign airway diseases underway, as well as the treatment of asthma via bronchial thermoplasty. So these are some things that we are getting more involved in, and you will hear about in the future. Here's our bronchoscopic surgery center. We have 4 rooms for bronchoscopic procedures, 3 of which are appropriate for general anesthesia, and 1 that is used primarily for thoracocentesis procedures. One of the things that we do quite a bit of is electromagnetic navigational biopsy procedures, where a CT scan is matched up with an electromagnetic navigational map, and you can tell where you are with respect to a previously recorded CT scan, which is registered with the device. And as you go through with your bronchoscope, you can tell pretty much exactly where you are, which facilitates obtaining biopsies at distant structures. The configuration for electromagnetic navigation involves a bronchoscope. The super dimension system is one of the ones that is available for this procedure. Endoscopic ultrasound is needed and fluoroscopy is needed. On the top on the left, you can see my colleague Basim Abdulmalik, the director of anesthesia for bronchoscopy, and he has pioneered a lot of the work here. On the bottom, you can see the C-arm in progress for the use for fluoroscopy. So one of the things we do a fair amount of is endoscopic ultrasound for mediastinal staging, and it's done with transtracheal aspirates or transtracheal aspirational biopsies, done with fluoroscopy and endobronchial ultrasound. Another procedure that we do is bronchoscopic lung volume reduction. This is primarily investigational and is an alternative to open lung volume reduction surgery. The endobronchial one-way valve allows for a one-way exit of air and mucus. And as an example, you can see here the patient left lung has this huge bolus that we want to be able to reduce because of the emphysema. So we want to reduce the volume of that lung. This is done, for example, using these intrabronchial valves. The spiration system is one brand of these valves, and you can see that they're placed endobronchially. Here is another example right here. And the idea is that it goes in through the fiber optic bronchoscope and is placed under bronchoscopic guidance. Here is a follow-up showing on the left the pre-op chest X-ray with flattened diaphragms, and on the right, more normal diaphragms after the placement of the valves in this. And you can actually see the valves in the X-rays if you look closely. Here is one of the studies about the patients for bronchoscopic lung reduction surgery. This age population was 48 to 77 years old. FEV1, about 29% of predicted. Total lung capacity, very large, of course, for this emphysema, 132% of predicted. Residual volume, huge, 227% are predicted, and the diffusion for carbon monoxide, only 36% are predicted. So this is an example of some of our patients, and these patients benefit from lung volume reduction procedures by the valve technique as opposed to an open surgical technique. Another thing we do is the placement of stents. It's a prosthesis supporting hollow tubular structure named after a dentist called Charles Stent in the 19th century in England. We know stents because they're put in coronary vessels, in the esophagus in the case of malignancy, in vascular structures as well as biliary structures. And here we put them in endobronchially. One common kind of stent that we put in is a self-expanding metal stent. Another type is a silastic stent that we'll be taking a look at in a while. These are made of silicone. And of course, they open up the airway structures, often in the case of malignancy. Sometimes these stents go bad, as you can see with some examples here. You can have the formulation of granulation tissue that can be a problem. And sometimes we're faced with the challenge of removing these stents. So here are some of the terms of engagement, so to speak, for use of stents. They're considered when all other options fail. There's no prophylactic stents, really. They're only placed when there's an identifiable problem. If you put in the self-expanding metal stents, they're basically permanent, although they can be removed with some difficulty. When therapy for STEMS-related granulomas fail, consider bronchoscopic removal, and it requires special expertise. Here's an article we wrote on this, Anesthesia and Airway Management for Removing Pulmonary Self-Expanding Metal Stents. I refer you to that article should you be interested in more information. One of the challenges you can get with this, though, is retained stent pieces, mucosal tears with or without bleeding, reobstruction requiring new stent placement, a pneumothorax can occur, damage to the pulmonary artery can result in death, unwanted permanent incorporation of retained fragments into the tissue may be needed, and occasionally cardiopulmonary bypass may be instituted urgently in complicated cases. So it requires a special degree of expertise for doing this. However, we do a fair amount at our center. Here's an example of some stent removal products from a self-expanding metal stent. In the future, we'll have new designs for self-expanding metal stents. They may include radiation-emitting stents that reduce the likelihood of granuloma formation, or bioabsorbable stents that hopefully will eliminate the need for removal of some of the stents subsequently. Silicone stents are also popular. And here you can see a silicone stent placed at the carina that is being polished with a Dremel polishing device, a grinder, and they are inserted bronchoscopically, often with a rigid bronchoscope. And these are more easily removed, and they are relatively easily placed. Another procedure that we carry out is the use of tumor ablation and other procedures with a neodymium YAG laser. The laser beam can be delivered via flexible bronchoscope. It is a high energy, deep penetration type of laser beam. And because of this, the potential for delayed complications, particularly related to edema or damage to structures that can be bleeding, can be a problem. Laser fire concerns exist for all lasers, in particular for this one. You want to avoid nitrous oxide, which supports combustion. You want to keep your fraction of oxygen in your expired gas below 40%, and you'll want to use saline-filled endotracheal tube cuffs. So some of the complications that we can get with this laser procedures are described in this article, again from Dr. Bassem Abdelmalik, the director for anesthesia for the bronchoscopic center that we have, and respiratory arrest resulting from airway edema is one thing you have to look out for. So these people should be monitored carefully for a longer period of time than normally. Another procedure that's sometimes done in case of malignancy is the insertion of radioactive isotopes directly into a tumor bed under fiber optic bronchoscopy, either for the palliative treatment of airway obstruction or for hemoptysis. It can be done under local anesthesia with sedation or with general anesthesia. So this requires a special experience and process that we are capable of. Another thing is cryotherapy, the therapeutic application of extreme cold for local destruction of tissue. Nitrous oxide is used as a cryogen applied through a fiber optic bronchoscope. Frozen tissue is destroyed by coagulation and necrosis, and it's an alternative to laser without the fire and without perforation risk or reduced perforation risk, and without the smoke plume that can contain particles that are dangerous to the operator's health. Another procedure, balloon dilatation. It's an effective palliative procedure for airway narrowing, and it can be done under direct vision using a fiber optic bronchoscope or using a rigid bronchoscope. The dilatation procedure is very stimulating, so it's often recommended that we do it under general anesthesia. On the bottom left, you can see a concentric web-like tracheal obstruction, and on the bottom right, you can see after laser resection and balloon dilatation is much larger. The pathway has larger cross-sectional area and makes it easier for the patient to breathe. So this can be very helpful. Here's an example of one of the balloon dilatation machines that you can get. It is filled with saline, and there's a pressure gauge in black, as you can see there, where you can gauge the pressure, and then it's done for a particular period of time and then removed. Often done in conjunction with laser surgery as well. Now, what about anesthesia for these procedures? Ordinarily, pre-medication is only done in a very anxious patient, and if they are pre-medicated, they should never be pre-medicated and left alone. Keep an eye on them. Judicious use of sedatives is warranted in small titrated doses. Typically, that might be, for example, 1/2 milligram of midazolam at a time or 25 micrograms of fentanyl at a time. Note that both of these drugs can be reversed with specific antagonists should you find that they are excessively sedated. Later on, we'll talk about dexmedetomidine as a sedative that can be useful. Intraoperatively, topical anesthesia and sedation should be used for some of these procedures. Topical anesthesia with 2 or 4% lidocaine can be helpful. General endotracheal anesthesia is required for most of these procedures. We'll talk about that in more detail. TIVA, total intravenous anesthesia, might be a better technique in that you have more control over the anesthetic agent's delivery when you're going in and out of the airway with some procedures. Muscle relaxation is often required when an immobile field is needed for precise airway measurement or for precise use of a laser. Here are some of the reasons why we like total intravenous anesthesia. You avoid polluting the room with inhaled anesthetic agents, ensures continuous delivery of anesthesia despite possible ventilation leaks, and allows for the application utilization of intermittent apnea or jet ventilation techniques. And commonly we use propofol or propofol in conjunction with remifentanil, depending on the particular clinical circumstances. The choice of the airway will depend to a large extent on the procedure. For subglottic and upper tracheal lesions, we use a supraglottic airway such as a laryngeal mask. And an iGel is a popular procedure that we carry out for this because it doesn't require that we inflate the cuff. For lower tracheal or bronchial lesions or defects, we use as large a tube as possible to allow room for the bronchoscope and for ventilation. And often that's an 8.5 or even sometimes a 9 tube. Use of a fiber optic swivel connector that I'll show you in a moment allows continuous ventilation and avoids circuit disconnection during bronchoscopy. And finally, rigid bronchoscopy that I'll show you in a moment is another technique. So here you can see the swivel adapter and a fiber optic bronchoscope going through our endotracheal tube. Here the endotracheal tube has been cut short a bit, and that just makes it a little bit easier for the bronchoscopist to manipulate the bronchoscope. And you can see the adapter that the bronchoscope goes through, and you can still ventilate through that if you have a sufficiently large tube. On the left upper, you can see the use of a rigid bronchoscope associated with a ventilating sidearm. And this patient is getting total intravenous anesthesia, but you can deliver vapor through this, but it pollutes the room and it's not as well controlled when the bronchoscope goes in and out. You can also see that electroencephalographic monitoring is being carried out in this patient using, in this case, a BIS monitor that would help with assessing depth of anesthesia. On the right, you can see the patient being ventilated by hand through the ventilating sidearm of a rigid bronchoscope. And here's just another view of our bronchoscopic suite showing rigid bronchoscopy being carried out in this setting. So there are a variety of alternative techniques to airway management that are sometimes worthy of consideration, and we sometimes use the ventilating rigid bronchoscope I've already introduced you to with the ventilating sidearm. Sometimes suspension laryngoscopy with jet ventilation is carried out. Sometimes intermittent apnea is carried out where patient intubated, extubated, intubated, extubated. And special attention should be paid to disruption of the airway. In these cases, when there's disruption of the airway, frequently we want to maintain spontaneous ventilation, and we want to avoid worsening a pneumothorax or a pneumomediastinum with positive pressure ventilation. And so when the airway is disrupted, such as a tear in the trachea, we have to be especially careful, and maintaining spontaneous ventilation is sometimes that we do. If you're using jet ventilation, here is a typical jet ventilation adapter, and the hose hooks up to the 50 pounds per square inch wall source. That, remember, is around 3,500 centimeters of water pressure. And of course, if you're jet ventilating through a narrow bore catheter, that is offers the potential for barotrauma if you're not careful. We use an adapter or regulator to reduce the pressure to the minimum acceptable amount to see the chest rise and fall with each breath. And so this is a simple jet ventilator. There's also advanced mechanical electronic jet ventilators, such as the monsoon system, that do all of this electronically. Now, one of the things that we sometimes use in special cases, and I'll give you an example of this in a minute, is dexmedetomidine. It's a drug given by infusion that has a unique form of sedation. The patients are sedated and appear sleepy, and if stimulated, they're easily aroused, cooperative, and communicative. The patients can then return quickly to sleep. And what's interesting is that the sedation is more akin to a natural sleep than most other anesthetic agents, because it acts primarily on the locus coeruleus, as well as a variety of other structures, because it's an alpha-2 agonist. Of interest, there's no compromise of the respiratory system, with CO2 levels resembling that found in normal sleep. And so because this drug doesn't have respiratory compromise compared to other drugs like the benzodiazepines and the opiates, it's a unique sedative that can be useful in some of these procedures. So here's an example. We have dexmedetomidine as the sole sedative for awake intubation in management of the critical airway. And this is an article in the Journal of Clinical Anesthesia from our center. And again, primary author is Bassem Abdelmalek, the director of the Bronchoscopy Center from an anesthesia perspective. What you can see in this particular X-ray is the airway is enormously deviated, and you can look around here to see that. And so you can see that this is definitely a problem, critical airway. Now, I want to go on a literary diversion. You may know about the 4 horsemen of the apocalypse. This is death, fame, war, and plague. Well, I want to talk about the 4 horsemen of the apocalypse as it pertains to anesthetic management. Here is a wood carving from the 1500s. And the 4 horsemen of death, famine, war, and plague are affecting mankind. Well, here is the 4 things I worry about most in anesthesia, not death, famine, war, and plague, but my 4 horsemen are aortic stenosis, pulmonary hypertension, anterior mediastinal masses, and enlarged lingual tonsils. Those are the 4 things that scare me the most in anesthesia. Although it would be very easy to add extra things to the list, such as a severe left ventricular failure, as an example. Why is this relevant? Well, here is a case we did, dexmedetomidine for anesthetic management of anterior mediastinal mass, and you can see the mass here is huge, and we use dexmedetomidine for sedation in this case with topical anesthesia. So to summarize our results so far, our talk so far, bronchoscopic surgery is evolving, and in fact, evolving dramatically. Patients or anesthesiologists need to stay up to date with new procedures as we share the airway with our proceduralist colleagues, particularly bronchoscopists and in some cases thoracic surgeons. Flexibility is needed to tailor. And thank you very much for your time, and I look forward to answering any questions that you might have.
Thank you very much, Dr. Joan. It appears that we don't have any questions on the chat or in the question and answers, but I have a question myself, if you don't mind, because I'm not that experienced with the dexmedetomidine. If the patient is sedated with dexmedetomidine, does this require a specifically quiet operative theater so that the sedation is not disrupted, or they are like properly sedated?
It's not deep sedation such as you would get with remifentanil or with large doses of midazolam, or especially with propofol. But it doesn't require that you have an especially quiet operating room. And as you know, operating rooms can be very noisy.
Yes.
But it turns out that I don't think that's really an issue. It's like they're going to sleep, and yet you tap them and they can wake up. Now, this, of course, is if you use the standard amount, which is typically a loading dose of a microgram per kilogram over 10 minutes, and then 0.2 to 0.7 micrograms per kilogram per hour. And notice I said per hour and not per minute. Most drugs given by infusion are micrograms per kilogram per minute. This is micrograms per kilogram per hour, typically 0.2 to 0.7. If you're in the high end of that range, they'll be adequately sedated a lot of the time, sometimes not. And it's not uncommon that if we need a little more sedation, particularly when they're injecting local anesthesia and it hurts, to add a little bit of propofol, 10 to 20 milligrams, for example. So like sedation, it's an art. And the amount that you give will depend on your clinical experience and the comorbidities of the patient.
We actually replaced remifentanil in our institution by dexmedetomidine. 90% now of all sedation procedure, like fiber optic activation or any procedure like that, we use dexmedetomidine rather than remifentanil like before.
Oh, that is good to know. Yeah.
Okay.
Thank you. Thank you, Dr. Jordan. Thank you, Dr. Saad.